Hello, Wayne County students. Here we are again. We're going to start from the physiology portion of anatomy and physiology. Let's take a look here at some things I've already written on the board. Pulmonary volumes. Pulmonary volumes. Here we have the inspiratory reserve volume. That will be all of this section here, inspiratory reserve volume, and that will include this. And I guess you can include that too, but let's just say it's all this section. And I'll go over what each one means, even though you can read it here. I'll go over each one. The tidal volume here, the TV, here is this line, this wiggly line here. That just really shows how we're breathing in and out. Just normally how I'm talking to you. Expiratory reserve volume, that's this area here. Expiratory reserve volume. And then we have the residual volume here. That will be this section down in here. All right? So at least we know the inspiratory reserve volume, tidal volume, expiratory reserve volume, and residual volume. The way the graph is being conducted. It looks a little different in your book, but since I already learned it like this is the way I'm going to teach it. But you can, and I think you'll understand it too. So let's look at tidal volume. Tidal volume, or TV, tidal volume is the amount of air inspired or expired with each normal breath. Amount of air inspired or expired with each normal breath. So, in other words, that is the way we normally breathe. Here's tidal volume here, breathing in, out, in, out, in, out, in, out, in, out. So you get the gist of this? This is how we normally, you sitting at your desks or sitting at home or just relaxing. Usually this is how much we breathe in, like I'm breathing now, just regular. That's about 500 milliliters of air in and out of the lungs, about half a liter, right? About 500 milliliters, okay? Then we have the inspiratory reserve volume. Inspiratory reserve volume is this entire section here. This is the air in excess of tidal volume that moves into the lungs on maximum inspiration. So here we are breathing normally at tidal volume, and then we're going to take a deep breath in, the maximum inspiration we can do. As much air as your lung can hold, that would be this. The inspiratory reserve volume in excess of tidal volume. Okay, here's tidal volume. This is an excess of tidal volume. That moves into the lung on a maximum inspiration. All right. Let's look at expiratory reserve volume. You would probably guess that yes, that would be the opposite of inspiratory. You'd be right. Expiratory reserve volume, ERV, is air that can still be breathed out after normal expiration. So after you're breathing in, out, in, out, in, out, in, out, in, out. So here, this is the amount of air that you can still breathe out from tidal volume. All right? All of this air is what you can breathe out after normal breath. Residual volume, RV, this is air remaining in the lung after your maximal expiration. After you breathe out every bit of air you can possibly breathe out, the residual volume is the amount of air that remains in the alveoli. It remains in the lung. So residual volume is air remaining in the lung after maximal expiration. It cannot be forced out under normal conditions. In other words, you can have, for example, let's draw an alveolar duct, the alveolar sac, and then the alveoli here. And I'm just going to put a little line here to show that that is the residual volume. Under normal conditions, this residual volume is going to remain in the lung. But what's abnormal would be it's a person getting stabbed. That will now break up the integrity of the respiratory membrane, and this air from this alveolus and all the other alveoli, all that air, even the residual volume, can escape at that point. So that's something for you to remember. Some people say, I got the breath knocked out of me. Fortunately, all the air didn't get knocked out of your lungs, but the residual volume is what remained. So that's a good thing. That way your alveoli don't close completely and have to try to struggle to open back up, because there's always a little bit of air under normal conditions that's left in there. And of course you have the surfactant that we talked about before that lines each alveoli and makes the lungs more compliant. It makes the compliance of the lungs easier, and which makes breathing easier. So this is the chart that you should be familiar with in terms of volume, but even more so under knowing the capacities. So let's use the same thing and look at capacities. I'm gonna erase a little bit of this, and then we will introduce capacities. Now capacities are going to be these volumes that we just discussed: tidal volume, inspiratory reserve volume, expiratory reserve volume, and residual volume. Any of those two, sum of those volumes will be capacity. So capacity is the sum of two or more of the volumes we just went over. So we can take inspiratory reserve volume plus tidal volume, add those up, that would give us a capacity. Tidal volume and expiratory reserve volume, you can add those two up, you can get a capacity. You could take inspiratory reserve volume, tidal volume, expiratory reserve volume, and you can see that would give a capacity. So two or more of these volumes will give us a capacity. Let's look at vital capacity. Excuse me. Excuse me. Vital capacity is going to be equal to tidal volume plus inspiratory reserve volume plus expiratory reserve volume. Okay? That would make this tidal volume here, excuse me, plus inspiratory reserve volume and expiratory reserve volume. That total volume is vital capacity. So that would be from here to here. Vital capacity. Okay? This is the largest volume of air that can be moved in and out of the lungs. You can't get any more in the lungs than breathing in as much as you can and out of the lungs on that expiratory reserve volume. This is the most amount of air that you can get into the lungs, and that's known as vital capacity. Vital capacity is dependent upon several things. Of course, the size of the thoracic cavity would alter a person's vital capacity. right? If you're a bigger person, like a big old, I don't know, football player, for example, you're gonna be taller, broader, and you're gonna need more oxygen and wider chest. You're gonna need to have a larger vital capacity to feed all the tissues of the body oxygen. Of course, that only stands to reason. A small, petite person, of course, their vital capacity will be less than the person that has a larger frame body. Your posture also influences your vital capacity. You can increase your vital capacity when you're standing erect and your posture is straight, as opposed to being stooped over or supine, right? We talked about the size of a person. A larger individual will have a higher vital capacity than a smaller person. If the things that can decrease the vital capacity would be if the lungs became congested. For example, they have too much blood in them due to congestive heart failure, where the heart is not pumping the way it should, so the lungs become congested and filled with blood. That is going to make you have a much smaller, or decreased vital capacity. When the lungs are filled with congestion, you're not going to be able to inspire maximally or expire maximally. You can also decrease the vital capacity with a protuberant abdomen. For example, if the person has ascites, that's fluid in the belly. That will make the vital capacity less, because that protuberant belly, the poked out belly, is pushing up against the diaphragm. And you know, in order to breathe, the diaphragm has to come down, flatten out, in order to accommodate an expanding thoracic cavity. If it's not able to come down, then you aren't going to be able to have a good, decent vital capacity. In addition to that, it doesn't always have to be pathology that causes a decreased vital capacity due to a protuberant belly. Pregnant women, especially in the third trimester, has their organs kind of pushed up, juxtaposed to the diaphragm, and that prevents the diaphragm from going down. So they too would have a decreased vital capacity, and that is not a pathology, it's just pregnancy. So usually you see those people, especially third trimester, they'll breathe through their lips, and they're kind of tight, and we call that pursed lips. Like they'll breathe like, they're just trying to get some air in. So, been there, done that. So I know about that. Also, persons that have a COPD, and we know that emphysema is the poster child of COPD, emphysema. Then the alveoli, the vital capacity is going to definitely be decreased. The alveoli are going to lose their elasticity, right? The alveoli are going to lose their elasticity, and they're going to be unable to recoil normally for expiration. All of these things can affect the vital capacity, and you can either increase compliance of breathing and having lung and gas exchange, depending on the size of your body, to increase vital capacity, or you can decrease your compliance and of the lung and decrease the vital capacity based on the position you're in and any disease or anomaly that may occur. The next one we want to talk about is inspiratory capacity. Inspiratory capacity this is inspiratory reserve volume plus tidal volume. Inspiratory reserve volume plus tidal volume. This sounds like the one we just talked about. This gives a maximum amount of air that's inspired after each normal expiration. This is the maximum amount of air that's inspired after each normal expiration. Not really gonna show that one because I'm really not that interested in that one, but I do want you to know about it. Let's look at this one, functional residual capacity. People are familiar with this one as FRC, right? FRC is going to go down and just get the residual and the expirational reserve volume. So it's going to be these two. That would be from here to here for functional residual. And the word residual is in there, so you'll know to go all the way down here to get the residual volume. You'll know to include residual volume. The word residual is in functional. A lot of people check the FRC just to see your how much air you can blow out, and that's an important factor to just see how much the capacity is in your expiratory capacity. All right, let's look at this one. Total lung capacity. Total lung capacity, TLC. Of course, the total lung capacity will be all of these volumes added up. So that's going to be the inspiratory reserve volume plus the tidal volume plus the expiratory reserve volume and of course the residual volume. That is the maximum amount of air that a lung can hold, right? This is the amount of air, the total volume of air that a lung can hold. Yeah. So that would be from here all the way to here. TLC, total lung capacity, right? That's pretty much it for the volumes and capacities. I did want to kind of remind you of something that we learned about when we did the heart, that sensors that provide feedback information to the medullary rhythmicity, the rhythm of how we breathe, is really an area that are in the chemoreceptors, the peripheral and central chemoreceptors. I think it's going to be a question on the exam, so I wanted to reiterate that you remember your central and peripheral chemoreceptors do communicate with the medulla to keep a certain rhythm of our breathing, okay? So volumes and capacities can be measured directly with spirometry. You ever seen those little kind of machines that sometimes they have you breathe in them and the balls go up and they're really trying to make sure that you, it's usually in the hospital after surgery or something. That's why they try to get you up as soon as after surgery or whatever has occurred. It could have just been for any reason that you may have been lying down for a while. They want to get you up and walking, get you up and active. But say you have been intubated, they usually, hospital staff want you to kind of breathe or expire, really. Some machines have you suck in, some of them have you blow out, but usually as you're checking your expiration, the breathing out usually is here. You're trying to do it for like a second, and you have to do that like 10 times or so. And the reason is because they don't want you to get atelectasis, meaning you don't want you to get fluid in your lungs, which can then proceed and cause a pneumonia. So they want you sitting up, walking around, breathing deeply so that you don't get atelectasis. So these volumes and capacities can be measured directly with spirometry because the pulmonary volumes are blown into the spirometer. So the thing I wanted to mention to you here is that the vital capacity is usually about, this is in theory, 4,500 to 5,000 milliliters. That's our vital capacity, as much as we could breathe in from normal down to where we could blow out or expire from normal. That's in theory. Total lung capacity, all the air that your lung can possibly hold. You don't need to know these numbers, but it's just fun to have them in mind. About 5,700 to, I think that's about 6,200 milliliters. So I'm just letting you know that your lungs can hold a lot of air, okay? So that's just to give you some point of reference, especially if you've ever seen those spirometers and you're trying to breathe up to a certain amount on milliliters. That just helps to keep that in mind, okay? Now I want to introduce a few terms that I need you to be familiar with. I'm going to erase this board now, and I'm hoping that you have all the information that you need. Of course, you know it's in your text, but I tried to go through the text and simplify things as much as possible, plus the fact I wanted you to have the gist of what the chapters hold. I know it's a lot of chapters, mainly because these new editions, the author has subdivided the chapters out. They used to just be all the respiratory in one chapter, but he subdivided it, and it makes it seem like, oh, now I gotta know 3-4 chapters, when really it used to just be one chapter. It's all respiratory, right? Of course, but on this exam, we're gonna have lymphatics and respiratory added. It's not, so that's the best I can do with it. Had to get lymphatics in, and of course the respiratory. That used to be considered just 2 chapters, but now I know it's 4, only because of the way the book was edited, not because it's a lot more information. It's not. All right, so I'm going to erase this, and we're going to go on to a few terms that I want you to be familiar with. And then we're going into pulmonary gas exchange. So just give me a sec. I'm going to erase this, and we'll move on to some terms and then pulmonary exchange. Gives you a little breather too. You can look over your notes a little bit. All right, this isn't unlike any class time, so. All right, so let's introduce a few terms. You could probably, let's see if you can see this. Alveolar ventilation, alveolar ventilation. All right. Alveolar ventilation is the volume of inspired air, so that's the air I'm breathing in, that actually reaches or ventilates the alveoli. So these two words actually tell you the definition of what it is. You definitely want air to reach the alveoli. And why is that? I think you recall, yes, that's correct. you recall that the only place we get gas exchange, the oxygen and the carbon dioxide, is in the alveoli. That's it. The alveoli have to be ready, presentable, and able to receive the oxygen to give it to the blood, as well as receive the carbon dioxide for us to exhale it as our waste. You have to remember that concept. And we have to keep that respiratory membrane clear in order for this gas exchange to occur. So keep all that in mind. So if we don't get air down into the alveoli and they do not become ventilated, that individual is going to be in serious trouble. That's called respiratory distress, right? So this is going to be the volume of inspired air that actually reaches or ventilates the alveoli. All right. Here's the alveoli. Let's just draw it. Oxygen or air has to come in here and reach that. Anything that blocks it from, anything that blocks the alveoli from getting that oxygen, that's going to be a problem. Thing is, I need you to realize this, that not all the air that we breathe is going to actually reach the alveoli. Not all the air we breathe reaches the alveoli. Some of the air will ventilate the alveoli, but not all of the air will be involved in the gas exchange. The air that is not involved in the gas exchange is called dead air. Any air that does not involve gas exchange in this alveoli is going to be called dead air. Okay? So I just want you to know that we're breathing, but not all the air is going to reach the alveoli. And then even the air that does reach the alveoli, not all of it's going to be involved in the gas exchange. As I told you before, we have residual volume there. We have some air that just hangs out in there in the alveoli. Not really involved in gas exchange. It's not going anywhere. Some of it's just sitting there. So that's okay. So that we'll say that not all the air, so let me give this, we'll just call it dead air. And I'll just put little quotes around it. This is air that we'll say that reaches the alveoli. But not involved with gas exchange. That's okay. You can come to the party, but you don't have to dance, right? All right. So dead air. I don't know why I said that, just make that up. Dead air this is the air that fills our larger passageways, and our larger passageways would include the nose, the pharynx, the larynx, the trachea, and the bronchi. Okay? This is also known as anatomical dead space. Now I want you to notice something with these words. Dead air, dead space. This is air that is not involved in gas exchange. So just remember, if your air is not involved in gas exchange, it's going to involve some kind of word with dead in it. Because really, if you don't have oxygen reaching your alveoli and not involved in gas exchange, that's what's going to happen. You're going to be dead. So you can put dead air, air that reaches the alveoli but not involved with gas exchange. And then dead air is the air that fills our nasal cavity, our larynx, our pharynx, and even the trachea. It has nothing to do with getting down here into the alveoli. So it's known as anatomical dead space, okay? Anatomical mainly because these are anatomical features, and this is just space. It's just like a, oh, what can you call it? A space filler. There's just air hanging out there. You know, you just always have air in those areas, okay? Other air due to disease, such as COPD, chronic obstructive pulmonary disease, that will not reach the alveoli, thus prevent any gas exchange, is also called dead space. So dead space doesn't necessarily just relate to this anatomical dead space. It's just that any air that doesn't reach or that's prevented from gas exchange is going to be called dead space. So we could have that from maybe you had it doesn't have to be a disease. In other words, I kind of want you to remember that non-pathological things can also cause a problem. You could have like eaten a big chunk of steak and it could have gotten caught in your throat. That, from now, you know, when that's stuck in your throat, you're not going to have good gas exchange because no fresh oxygen is going to be able to reach the alveoli. That could cause problems. You could be choking. Somebody could be choking you. That's going to be another problem where you're going to have dead space. You could be hanged or hung. I don't know. That's going to cause a problem. Allow for dead space because there's not going to be any gas exchange. So it doesn't always have to be some pathology. It could be other things as well. So it doesn't have to always be disease, in other words. So anatomical, I hope you can see this. Anatomical dead space, the one anatomical nose, throat, pharynx, trachea, etc., that dead space, plus any other alveolar dead space. Like I said, you could have COPD, or like I say too, it doesn't have to be a pathology, doesn't have to be a disease. Somebody could be choking you. You can be choking on a piece of steak or a big chunk of apple, whatever. That kind of dead space. Dead space. This is, and I'll just say due to disease or whatever. Due to disease, like our poster child of COPD, emphysema, or whatever. Like I say, choking. Anatomical dead space plus any alveolar dead space. This is going to equate to physiological dead space. And I like that because you get to see the anatomy and the physiology being used here. All right. Anatomical dead space plus any other alveolar dead space is going to do what? It's going to lead to physiological dead space. And that sounds like it's going to lead to not such a good outcome. All right? So that's really the gist of the breathing aspect of how we breathe and what's really going on. Let's go on into the pulmonary gas exchange, which I'm going to introduce now, so you can really kind of get a grip on what's going on in this alveolar system. So let's look at this. All right. So this is going to be the pulmonary gas exchange. All right. Now, in order to understand about this pulmonary gas exchange, we got to learn a little bit, know a little bit about pressure. So we have partial pressure, which is Dalton's law. And this is pressure that's exerted by any one gas in a mixture of gases. Now, we learned before when we were learning about things with the heart and blood and circulation, we noted that gas and liquids, in that case, blood was the liquid, they have a similar way of behaving, especially when it comes to how they behave with pressure. So with this one, the same principle, because this is gas now, and in our case, the gases that we're concerned with are oxygen and carbon dioxide. These gases will behave similarly to the way we looked at fluids. All right, so let's take a look at this. Suppose you have, this is Dalton's law. P sub T is equal to P sub A plus P sub B plus P sub C. Okay? This is all Dalton's law. You know, these guys, they had a lot of time sitting around thinking kind of like we do now. So he just thought of it. He just looked at the oxygen, or he just looked at the composition of the air in the room or wherever he was. He was like, I wonder what is this stuff made of, this gas that we breathe in. Like, who would think of that? I don't know. But he said, what's the total? Now we know that our total in our atmosphere, what was that number I asked you to remember before? It is the number du jour of respiratory. Good. 760 millimeters of mercury. So when we talk about pressure, we got to remember the units, millimeters of mercury, mmHg. We got to remember that. So he started thinking about, well, what kind of gases are in this room? This total room and the total gases in this room, or in the atmosphere. What gases make up all the gases in our atmosphere? What are A, what are B, what are C that make up this total T? That's an excellent question. So he took the total partial pressure of a mixture of gases, and he determined that the sum total, he determined that it is the sum total of each individual gas. I should have put each individual partial pressure of gas. Yeah, I'll do that. Each individual partial pressure of gas. All right. Good. So how did that turn out? Well, let's look at the concentration of the atmospheric gas. So let's just say this is our atmosphere. We're just going to make it, this is our total atmosphere of, let's say, what our atmosphere is, 760 millimeters of mercury. And that, of course, is our room. That's the campus of Wayne County Community College. That's our atmosphere. We're not up on a mountain in Mount Kilimanjaro, and we are not in the depths of the ocean. So this is going to be our atmosphere, 760 millimeters of mercury. Now, that's the total. That's the piece of T. But what gases are in that total? That's the piece of A, the piece of B, and the piece of C. The partial pressures. Here, we'll take a piece of this, a chunk of that. This is 21% oxygen. 21% oxygen. We know this is 100% because that's our whole atmosphere. That's what our atmosphere is made up of, 760 millimeters of mercury. So that's 100%. Out of that 100% of that atmosphere is 21% oxygen. That comes to about, really, if I want to use it in terms of millimeters of mercury, that's about 160 millimeters of mercury. I know in your text it's about 159 point something, but I just rounded it to 160, okay? Another little part of this, another small part of our total atmosphere are other gases. So let's just draw that, other gases. And that's about 1%. We'll say that's other gases. If you can read that, let me make that a little neater. About 1% are other gases. Okay? And that comes to be, in terms of millimeters of mercury, about 3 millimeters of mercury. 3 millimeters of mercury out of that 760 millimeters of mercury, which is our total atmosphere. The rest of our atmosphere, the majority of our atmosphere, and all this gases that we're breathing, it's really, the rest of this is nitrogen. And that's about 500, okay, so we said, let's put it in percent first. That's about 78%, which comes out to be, in terms of millimeters of mercury, 797 millimeters of mercury. Now the point is that our atmosphere is made up of mainly nitrogen. And the interesting thing is, for us to be aerobic beings, we have to have this 21% oxygen. Without that, we perish. It's not going to be good. You can't have too much oxygen, and you can't have too little oxygen. The organism, which is us, won't fare too well. We need exactly the right amount of oxygen. And fortunately, Earth was able to supply that. And so you have these aerobic beings and organisms that are able to handle that precise amount of oxygen. Now you have to remember, oxygen can be toxic as well. So even in medicine, you have to write for oxygen, how much oxygen you can give a patient. So you have to keep that in mind, that everything too much is, well, I need more oxygen, give me more. You know, especially with premature babies, you have to be careful with that, because you can make them go blind with too much oxygen. So everything you must remember to have balance, okay? That's just science. You must try to always get yourself, your life, your system, your home in balance. So with the 21% oxygen, that's just a perfect amount for us. This 78% of nitrogen is just a perfect amount for us. And these other gases apparently is a perfect amount for us as well. The majority of the gases that we breathe, though, please remember, is nitrogen, and that's 78%. If you take these percents, Lord, I hope they add up to 100% so that you know that's how much is in our atmosphere. If you take these millimeters of mercury and add them up, I'm hoping that you also see that it too is what our atmosphere is. So the total 760 adds up or is equal to these partial pressures of gases. The partial pressure of oxygen, partial pressure of nitrogen, partial pressure of other gases. That's Dalton's law, just the best way I know how to explain it to you, all right? So now, this is a question that's going to be on the exam, just so you'll remember. The meaning, the partial pressure of gas in a mixture of gases is directly related to the concentration of the gas in the mixture and to the total pressure of the mixture. The partial pressure is related to the total and the mixture of gases that make up the total. You'll have time to go over this in your text, so when you see the picture of the text, it may make more sense to you. But that's the best way I can explain this, given what I have. So I think that's a pretty decent explanation. Let's look at the exchange of gases in the lungs, right? Before I go on though, I want to make sure that you look up the words in the text. You may have apnea, dyspnea, hyperapnea, things like that. Those are types of breathing. I don't really have them in my notes now, but I do want you to be familiar with that, and I think it gives you examples of that. For example, dyspnea is just a difficulty breathing. Again, it doesn't always, difficulty breathing, shortness of breath, dyspnea. It doesn't always mean that you have a pathology. If you're carrying about 7, 8 grocery bags and you live on the 5th floor and you have to take the steps, trust me, by the time you get to that 5th floor, you're going to have dyspnea. You have difficulty breathing. So it's not always a problem, but of course, if we see it in the case of an asthmatic, we'll say, yes, that is pathological, that's a disease, and yes, that's a problem. So the words can mean pathology, or they could just mean that, hey, the person's just short of breath. Nothing wrong with his lungs, though, all right? So when you read these things, read them with those types of things in mind. You want to always be able to compare so you'll know when somebody's in distress versus when somebody's not distressed, just simply out of breath. So let's take a look at the exchange of gases in the lungs. The exchange of gases in the lungs. And quite frankly, I think that's where we left off before we were quarantined. We left off with the exchange of gases in the lungs. So let's just take a look at that. How do these gases, and you know what gases we're talking about, oxygen and carbon dioxide. How do these gases get exchanged in the lungs? Good. So first of all, the gas exchange takes place where? Where does the gas exchange between carbon dioxide and oxygen take place? Correct, in the alveoli. That's the only place that we have gas exchange. Let me just use a little more of this board. So I'll draw an alveolar duct, an alveolar sac. And I'll just put the alveoli in here. It's, you know, it's a lot of them, about 150 million per lung. You remember that. So here are these little, very important little sacs, these alveoli here. And so gas exchange takes place between the alveolar air and the blood flowing through the lung capillaries. So let me just draw, we'll just say that's a capillary there. Let's put some blood in it. Some beautiful, plump, red blood cells going through this capillary. And of course, this alveoli represents the lung. So we're going to just take this out and let's just remove a little bit of this. And say, okay, here's the lung, here's the capillary. And what is the deal with that? Well, the main thing to remember, so it takes place between the alveolar air and, here's the alveolar air, and the blood flowing through the lung capillaries. Good. Gases are going to move in both directions, right? Across the respiratory membrane. You remember that this and this and that, all of that's part of the respiratory membrane. Gases will go in both directions across the respiratory membrane. Right? Oxygen enters the blood from the alveolar air because the partial pressure of oxygen in the alveolus is greater than the partial pressure of oxygen in the blood. Remember that. How is air from the lung going to get into the blood? And remember, the important part about getting oxygen into the blood is so that the blood can carry all this oxygenated blood to all the tissues of the body. That's the important thing. We learned that when we did the heart. What I'm expressing here is a gradient, a pressure gradient. It's going to go from higher pressure gradient in the lung to a lower pressure gradient in the capillaries of the blood capillaries in the lung. Okay? The lungs blood capillaries. So the oxygen that's in the alveoli has to be able to get into the blood. How does it do that? From a higher pressure gradient to a lower pressure gradient. That's how. And so oxygen will leave, let's see, put it in a different color. Oxygen will leave the alveoli and go to the blood capillary that's in the lungs, okay? That's what oxygen will do. Of course, it's all in the alveoli, like that. Oxygen enters the blood from the alveolus air because the partial pressure of oxygen in the alveolus is greater than the partial pressure of oxygen in the blood. Remember, just like when we learned with in the heart, when we did circulation, with blood being the fluid, fluid and gases have a lot of the same characteristics and properties and how they behave with pressure. It always flows, oxygen will diffuse down its pressure gradient from a higher pressure in the lungs to a lower pressure here in the lung capillary. Now at the same time though, this is another thing we got to remember, at the same time that oxygen is leaving the lung to get into the blood, the other gas, carbon dioxide, must exit the blood by diffusing down its pressure gradient, right? So carbon dioxide, well, I'll just draw another one. Here's carbon dioxide. And we'll draw a capillary here. Here's the blood in the capillary. Carbon dioxide is on the blood cell, but it's going to diffuse into the lung. And then we will breathe that out. Right? Same as opposite occurred here with the oxygen that we breathe in. So, here you got carbon dioxide leaving the lung. Why? Because there's a higher pressure gradient of carbon dioxide on the red blood cell to get off of it and go into a lower concentration or lower pressure gradient in the lung. And then we can breathe that out. Here again, you have the exchange of carbon dioxide and oxygen between the alveolar air and the pulmonary blood converts deoxygenated blood to oxygenated blood. This is now oxygenated blood, and this carbon dioxide leaving the blood is deoxygenated. Right? We're going to deoxygenate, we're going to take carbon dioxide off, deoxygenate it, take the carbon dioxide off, and then oxygenate the blood when oxygen pops on. No two gases can hold the same space at the same time. So once oxygen comes to pop onto the red blood cell, carbon dioxide must pop off of it. All right? And you must remember that carbon dioxide is our waste. If we retain or keep carbon dioxide, too much of it, because we do have a certain amount in our blood. I think it's like, you don't want to go over 40 millimeters of 40 to 45 millimeters of mercury. But the point is that if you go too much higher than that, that will make you acidotic. Right? Excuse me, make you acidotic. And you don't want that. So there's always a balance. Alveoli are constantly being ventilated to keep this system going, putting oxygen on the red blood cell and carbon dioxide off of the red blood cell. All right. Remember, it's going to be pressure gradients. It's a higher pressure gradient here in the capillary for carbon dioxide to go to a lower pressure gradient here in the lung, and then you breathe that out. Nothing different. Carbon dioxide, oxygen are going to work in the same way, just following pressure gradients. That's it. Now let me give you these things that you got to know. Well, you got to know that. But this is the amount of oxygen that diffuses into the blood each minute. It's going to be dependent upon these 4 things, which you're going to be responsible for knowing. So I think I'm going to ask this question verbatim. So we'll just put it here. Take a sec. All right, let's look. This is the amount of oxygen, and you can see this in your text, this verbatim. Amount of oxygen that diffuses into blood each minute depends on going to depend on the partial pressure of oxygen in the alveolar minus the partial pressure of oxygen in the blood. It's going to depend on, of course, having a functional respiratory membrane. You gotta have a good respiratory membrane in order for oxygens to diffuse across it. You remember when I showed you if you have a pneumonia or something that's blocking that respiratory membrane so the oxygen can get over to the red blood cell, or carbon dioxide can come off the red blood cell and get into the lung. Any problems with that membrane is going to be cause respiratory distress. This third thing is the respiratory rate per minute times the volume of air. Okay? And then the fourth thing will be alveolar ventilation. Make sure that's right. All right. So let's kind of look at these and see what we come up with. So the partial pressure of alveolar, the partial pressure of oxygen in the alveoli minus the partial pressure of oxygen in the blood. So if there's a decrease in oxygen, say like high altitudes, you have partial pressure of oxygen in the alveoli is lower. Therefore, it's going to be less oxygen that enters the blood at high altitudes because the atmosphere is going to be different. So that would affect how much oxygen gets into your lungs, which will definitely affect how much oxygen is going to be available to the blood, right? You've heard of people climbing, what do they climb? Mount Everest. And there's so many bodies on Mount Everest, and there's so much junk up there. People just keep climbing it. But it used to be a time when you were a real mountaineer. You would climb just up so far. You would camp out for about a few days, a week or so, and you let your erythropoietin kick in. This is a hormone from the kidneys that will fortify your blood, make more red blood cells, so you would have more oxygen. Then you could climb a little bit more, few feet or whatever, maybe, 1,000 feet. Then you camp out there, let your blood acclimate again, more erythropoietin kick in, and then you could climb some more. Now, they're kind of cheap. They just put an oxygen pack on and go up. Everybody always talks about the person who reached Mount Everest. Oh, he put a stake in. But Sherpas do that day in and day out. They have guides that do this day in and day out. You talk to some Sherpas, they probably been up and down that Mount Everest about 100 times or more. But people who do it for sport, they really, oh yeah, I climbed Mount Everest. The Sherpas are going, yeah, I do this daily. This is my job. So, everybody's achievement is different. That's, it may be a big deal to you to make it to Mount Everest, but, people say, well, why climb the mountain? Well, because it was there. Yeah, okay, whatever. Functional respiratory membrane. You need a functional respiratory membrane with, I would say, with a functional surface area. This is where, so you need a functional respiratory membrane, that is true, with a functional surface area. For example, let's just draw an alveolus here, and we put some alveoli in there. If a person has the poster child COPD, chronic obstructive pulmonary disease, and we know that the poster child for COPD is, yes, emphysema, then these alveoli are not going to be so nice and round, are they? No, because they've been destroyed. Their elastin is destroyed. They're not so compliant. They're not going to be able to recoil and open up because it's like bubble wrap. You've played with bubble wrap before. It's like if you pop all the bubble wrap, there's no going back. No more air is going in there. You will not use that for packaging. So these, the functional surface area with emphysema is no longer a functional surface area. It's not a good way to exchange gases because there's no gases in here. They kind of convoluted and made one kind of big old alveolus instead of the four that were there. That's pictorially, that's the way emphysema looks. And you can also imagine it as bubble wrap being popped because they never come back. Once the integrity of an emphysema lung is messed up, then that's it. There's no repairing it. So you're not going to have a great amount of oxygen diffusing into blood when you don't have a surface area of alveoli. And that's why you see a lot of people walking around with those nasal cannulas of oxygen. Usually it's because of some chronic obstructive pulmonary disease. And I'll just say for the sake of the poster child being emphysema. So we're looking at the amount of oxygen that goes into the blood, diffuses into the blood each minute. First of all, you got to have some oxygen in the lung to go to the blood. Secondly, you got to have a good respiratory membrane and a good surface area. If this all busted up like this, that's not going to happen. Oxygen going into the blood each minute is going to be way low, down. Your respiratory rate per minute, how fast you're breathing per minute. Usually, you guys are taking vitals many times. Maybe it's like 18, 20, something like that we breathe in and out each minute. And then the volume of air that person breathes in. Remember, your thoracic cavity is going to be different than somebody else's. They could breathe in more air than you. Or maybe you could breathe in more air than them. Anyway, that's going to depend on how much air you're getting in. And how often you're respiring, how often you're breathing. That will affect the amount of oxygen that diffuses into the blood each minute. I say that to say that if a person is sedated, or even if they aren't sedated, but they're taking morphine or some type of drug like that, it's going to reduce your respiratory rate, which will then affect the amount of oxygen that's going to diffuse into the blood each minute. If your respiratory rate is lower, you're not going to get the amount of oxygen into the blood that you normally would when your respiratory rate was normal, right? Alveolar ventilation, we know that you have to have a certain amount, a certain volume, or any type of air reaching the alveoli in order for you to ventilate the alveoli and get gas exchange. So that's definitely going to affect the amount of oxygen that gets into the blood each minute. I need you to read these things not to memorize, but to understand. That's why I try to give an example with everything that I do when we go through the lesson, right? I don't want you just memorizing. The stuff needs to make sense. So take your time, go through it, and ask yourself, does that make sense? Because when you take the test, you're going to only have a minute per question. So I need you to understand the concepts and be able to grab that information quickly from the recesses of your brain. This is not to make you nervous about anything, but this will test if you know the information or not. You can't dilly-dally. You got to know it. So that's why I'm going over it, so it will make sense to you. How blood transports gases. Let's go into that. That is another section that we will get to on how blood transports gases. Of course, the gases will be carbon dioxide and oxygen. And we will look at the ways that blood transports oxygen in a minute.